Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical application of business acumen essential to successfully navigating today's rapidly changing business environment. I am Dr. Micheal Darson, and in today's episode, we will discuss the financial aspects of running a urology practice and how to optimize them for success. Joining me today for this discussion is Dr. Jennifer Miles Thomas. Dr. Miles Thomas is a diplomat of the American Board of Urology and board certified in female pelvic medicine and reconstructive surgery. She provides specialized care in female reconstructive surgery, pelvic prolapse, incontinence, complicated urinary disorders, and disorders of the urinary system due to neurologic disease. She is currently the CEO and president of Urology of Virginia and medical director of the Pelvic Health Program at Chesapeake Regional Healthcare. Dr. Miles Thomas, welcome.
Thank you very much. It's a pleasure to be here.
Great. I'm really looking forward to you sharing your experience running a urology practice. So let's go ahead and get started. Can you help us with a better understanding of revenue streams in the urology practice?
Sure. It's a little bit more complicated than meets the eye. And what I'll try to do is kind of break down the different sources of revenue or income coming into the practice so that people can kind of understand that there's different components and there are different expenses that are attributed to these different revenue streams. So the most obvious one, of course, is like patient revenue, right? But when you look at the patients themselves, there are different streams. So there are private pay patients that who pay cash, no insurance whatsoever. There are patients who have private insurance, and that would be like the Blue Cross Blue Shields, the Aetnas, the Cignas. There are patients who have Medicare or Medicaid. And then there are also ancillary services where patients pay, let's say for labs, or if you have a CT scanner or an X-ray. So all of these are sources of revenue that patients are receiving a service and then they're coming into your practice. It depends on what type of state you live in. So if there's a need for a certificate of public need or not, you may have more ancillary services than someone else who's in a neighboring state. So that means that some states require you to demonstrate that there is a need for that service before you can just have that service. While some states, it doesn't matter. If you have the money, you can basically buy the machine and then you can start providing that service. So sometimes you could have PET CT scanners, you can have MRI machines, surgery centers or ASCs would also be other revenue sources into your practice. But one of the things that you do need to think about is the mix. So the reason we went into urology is because we have this calling or this need to provide this service, right? We have many options in the world of what we can do for our lives, for our careers, but we chose to do urology because we feel the need to give back in a way that is a little bit different than general surgery or ortho or family practice. But what we do have to pay attention to is our patient demographics and mix, right? Because the idea is urology is full of 65 plus year old men. Well, you can see clearly from me, there's a different demographic that also is present, that's providing services and also utilizing the services. So some of the things you need to think about are what services are you providing? So in the old days, it used to be you're either getting a cysto or a biopsy, right? That was basically the services you provide. But think about what we do now, right? We do vasectomies, we can do sedation, we can do urodynamics in-house. Some people have interventional radiology centers. Definitely, we discussed there's imaging. So you want to be able to assess what is your encatchment, what is your draw. So you want to make sure when you run through your RCM, your revenue cycle management program, you want to see, okay, I have 40% Medicare. I have 70% Medicare. Well, what are the top types of CPTs, or what type of procedures am I doing? Am I getting a good mix? Do I feel that I really want to provide X service even more? Do I need to market for that service? Who else is in my community? Who else is able to provide these services? So you really got to think about urology as a business, and you got to figure out, here's what we like to do. Here's where we're receiving maximum ROI, or return on investment. Here's what the population needs, and let's see if we can provide it. The other thing that you really need to spend a lot of time on, because I would say in residency and in med school, you get zero training. Well, I wouldn't say zero, minimal training. And that's coding and billing. But that is so important. One, to appropriately get reimbursed for your time and your expertise. It would be different if all of us could show up and in 2 years we could be urologists. But most of us dedicated our 20s and our 30s into either studying or training to be in this profession. So you want to make sure that you get every single benefit you legally can. Completely legally, there is a way to maximize billing, and that's learning the rules, knowing the rules, and applying the rules. The problem is we're not always trained to do that. And so there are multiple courses you can take. There are webinars you can sign up for. Most practices have a billing and coding team, and they should also be going through audits to make sure that what we are sending out for reimbursement is actually correct. But we need to learn how to bill and how to code. And the rules change every few years. The rules change about what needs to be in your notes. I know when I started, I wanted to make sure all of my notes were as flowery as possible, and that anyone who ever read my note was like, oh my gosh, this is like a great academic urologist. And then the rules changed and the number of patients I had to see. And then I realized, when I'm reading someone else's note, I want to know what the patient came in for and what the plan is and what they're going to do. And so I've had to rework that, because in the New World Order, billing isn't based upon, well, one, it's based upon time and also different criteria, but it's not based upon my flowery language or my full sentences. And I had to kind of get over that and recognize that's just there for documentation and billing. Everyone who's clinical wants to know what my plan is and what the patient complained of. The other thing we need to pay attention to are payers, insurance providers, right? Because we all feel like we're held hostage to, well, this is what they said they're going to give me. We honestly know that we are the commodity, right? There are not that many of us. More and more of us are retiring, and we are the ones who actually provide services. So from time to time, you have to look at your contracts. You have to compare your contracts. You should be able to have a database where you can compare what you get paid, let's say for a cysto, between all your payers. Now, you're not going to call CMS Medicare and basically say, I want to get paid more. But most of those contracts are based upon Medicare rates, and you can negotiate different rates. I mean, they have to have urologists in their network. They have to. And if you have issues with those payers, have that conversation. Don't be afraid they're going to drop you. If anything, they're more afraid that you're going to drop them.
What do you think the most important part of contract negotiations with an insurance company is?
Know your numbers. So you need to know exactly how many members you're taking care of. You need to know what you're billing. You want to know how fast they pay you. And you want to know what percentage of Medicare they're paying at. So the one thing that they are all, I don't want to say slick, but I would say inventive, is that occasionally they'll send you an email saying we're going to renew, but they don't have the rest of the contract with it. So you really have to go back, look and see, and you should have a spreadsheet with the most common codes you have. It should have everything in it, but the top should be the most common. And you should see what you're getting paid, because everyone knows our expenses are just going up. It's hard if you're competing with your MAs to keep them in your clinic where it's, fast paced, it's actually hard work, versus Chick-fil-A. You have to know what you're getting paid for everything to keep the lights on. You really do.
Absolutely. That's a great point. What, who in your practice does that analysis?
So we have a director of billing and we have a director of coding. So our contracts are usually on a 2-year basis. Some of them are annually, they update. The other thing is you have to pay attention to the APPs. So if your practice has APPs, some of the payers are credentialing them separately. So you have to make sure that if their rule is that they have to be credentialed, they're not going to be able to be the incident too. They're going to have their own credentials and have to bill for themselves. So what we do is we have a meeting and we go through, this is what we're getting paid for X, Y, and Z. And then, hey, is something going on? We would have what's called a variance report. So in your actual practice, RCM, revenue cycle management company program software, you should have programmed in there. All right, so Medicare is going to pay me $100 for this service, but I only received 27. So was there something that was the patient's responsibility? Was it not billed correctly? All of those things should be reconciled very, very frequently so you know where the missing money is. Because otherwise, what if they forgot to mail you a check? What if they forgot to deposit? You wouldn't, there's so many numbers coming in, so much money, and it's not labeled. John Jones paid X dollars when it comes into your lockbox or your account. So you really need to be very careful and reconcile it so you can go and search and get all of the money that you really did earn.
Going back to the role of efficient billing and coding, I have a practical question. How does your group handle physicians' timing as far as signing off on their notes?
Well, that's a great question. So our official policy is it needs to be signed in, I think, 48 hours. We usually give some leeway up to a week. And the reason is someone may be on vacation, someone's in the OR working late. Sometimes we really don't want people to burn out. But what we do is weekly, we send a list of unsigned charts with names attached. And the ones who have the largest number are in red so that it's clear who's kind of lagging behind. So I'm not saying like just social justice, but I'm saying that when your name is out there more than 1 week in a row and you're not on vacation, you hear about it.
Yeah.
Sometimes different organizations have other penalties, including, I know some are very, very strict and have fines if it's not signed. One of the things we also pay attention to and we communicate is that different payers have different contract rules, right? So if something happened and you forgot that one patient, let's say the UA wasn't in, you couldn't sign the chart, and it's been 90 days, guess what? You may not get paid anymore for that because it was outside of that time. A lot of doctors don't even recognize that because they forgot what happened in January, and it's just that one little dot that didn't get filled in. Other like CMS, you got a whole year. So we try to stay on it and remind people. But I mean, we are talking about doing a little bit more enforcement and not just the public shaming, but hey, you're going to be fined if you're really far behind.
Yeah.
Usually people, catch up when they're the straggler.
Yeah, it was certainly an issue at certain times in my practice as well. So it's always curious to hear how other practices handle that.
Yeah.
Let's go into managing operational costs for sustainability.
Yes. Yeah. Sustainability, that's a buzzword in any business right now. It's how do you maintain what you have? Because we are tired, right? There's less and less of us. There's more and more patients. And I can honestly say patients have changed post-COVID. So one of the most expensive item on any budget is going to be the workforce cost, the labor cost, right? So you really have to pay attention to the physicians, the nurses, the administrators, making sure you're paying market costs, because what's really expensive is that medical assistant who's a superstar who comes to you to say, hey, I want 50 cents more, otherwise I'll leave. And you're like, 50 cents, I'm already paying you, that's $500 an hour or something crazy these days. Well, how much does it really cost for you to recruit a new person, train the new person, get them up to speed to be that superstar who may or may not leave also? So you really got to evaluate your personnel. You really have to recognize what their strengths are, right? Because everyone isn't great at everything, but it's discovering their true talent. And you want to make sure that sometimes I've seen historically that because someone has a legacy at a facility that they get moved up in different management chains, but they don't always have the skill set. And so we really need to operate like businesses. We can identify the talent, we can promote the appropriate people, or we can train them to be in the role that we want them to be. The other thing you have to constantly reevaluate are your office leases, right? Sometimes we want to just like set it and forget it. We don't recognize when they expire or when they have the annual increase. But guess what? If your rent is increasing 3% per year, you got to figure out a way to increase your revenue at least by 3% a year just to stay in the same spot. You're not winning, you're just treading water at that point. The other thing that's concerning, and we clearly saw price gouging during the COVID pandemic with supplies, right? Now, we have someone who does product procurement. So that's her whole job, is to look for pricing, shop around, make sure that we're balancing what we're using and what we're ordering. But supplies, I mean, everything needs to be renegotiated. Sometimes you'll try to save 25 cents on a glove, but then you'll take it out and there's like no fingers. So you really got to balance the product, the quality, and then what you're receiving. I think at the end of the day, we're in business to provide like patient care. So it's the fine line of cutting costs as much as possible while balancing providing safe and quality care. So I think you can't get the cheapest price for everything. It's like, what is it? There's like, you can get the cost, or it can be as fast as possible. And I think there's one more, but you can't have everything at the same time. You got to choose like two of three. Though what I think is very exciting and is happening now is the use of AI and software. We are so hesitant to move to the 21st century because there's risk. Like, our entire career is balancing risk and benefit because we are significantly penalized for inappropriately assessing risk. So when these newfangled AI comes in and you can walk in the room and someone's talking to you, someone else is typing, and then there's a robot examining the patient, we're a little bit fearful that it's not as controlled or it may be inaccurate, and then we'd be at fault. But as we move forward, again, the most expensive part of anyone's P&L is going to be the labor costs. We have to be able to utilize software, AI technology to do things that do not require a significant input of like mental energy. Anything that just is moving paper back and forth or taking faxes should not be touched by the human hand. That should be something that's automated. And it's going to provide a significant cost savings. The other thing is, a lot of times you'll see promoted all of these new procedures, everything's expensive. You got to balance it with the bread and butter of what we know works and what the patient actually needs. So sometimes we get into a competition because this practice is offering the newest X, Y, or Z, and we want to offer it. Let's step back. What do the patients need? Does it really provide additional benefit? It may make us a little bit more money, but is it best for the patient? And that's what we have to balance.
Those are great points. I don't think you could have given a better example of the labor example with the medical assistant. That's, every physician that has had, a really good medical assistant really understands exactly what you were talking about. And I think another strategy that we sometimes used was when we had that star that came to us and said, hey, I really need a little bit more money to stay. We would try to find some kind of way to expand their responsibilities a little bit to help, justify the increase. And I think that's always a strategy that it can be successful. So.
I agree completely, because part of our roles as leaders are to recognize their strength and help professional development, because they're coming to us. They don't know all of the opportunities that are really there. They know what we're showing them. But if you see someone or a rising star that can be a superstar, yes. So maybe they do a presentation. Maybe you help them with public speaking. Maybe you have them become the pod leader to get and gain those skills while you're mentoring them, because you never know what they really could become.
Right. That's a great point. I was curious when you said you had a person that was in charge of procurement. What was their original position within the group? Were they a medical assistant or?
I think she was originally with like a radiology tech.
Okay, interesting.
Yeah, so it's kind of the roles that evolve when you're in a smaller practice that starts to expand, but we really needed someone. So since we have 360 some employees, we can't have everyone order whenever they have a whim because you never know if that supply is somewhere else in the practice. And so we had to have someone who knew exactly what was stocked, how it was stocked, knew what all of the purchasing contracts were, knew about different rebates we may get, have relationships with the different suppliers so that we could try to get the best. And especially during COVID, trying to get access to supplies. Those relationships were very important.
Mm-hmm. Great points. Let's talk about how you invest in practice growth.
Yes. So a wise person once said, if you are not growing, you are either standing still or you're retracting. The problem is in our world, you don't get multiple chances, right? So the first thing you have to do is invest in your people. And part of that is, like we said before, professional development, education. A lot of times we're hesitant to spend money on our staff. And part of it's because it's going out and we don't see an immediate benefit. It's not generating revenue for us. But things like conferences. How many times, if when you first were starting out in your career, did your job actually send you on a conference so you could network and learn, do things hands-on, understand really where you are in the ecosystem, and then have that network to say, hey, I need help. This practice is doing X, Y, or Z. That's what we do as physicians, but we should also offer that to our staff. Other things we should embrace: technology, facilities. A lot of times this is where our footprint is, but we should be looking like any other business. Okay, where is the population growth? Where are people moving to? Who's moving to that area? Who's going to need new access to our services? And then we should be targeting those areas because as we've seen during COVID, people, they don't want to travel as much. They're happy. I mean, people want to work from home, of course, but then also they like their communities and they want to stay in their communities. So should we be in their community if this is the up and coming area where there's massive expansion? Another thing that we have to work on that we're not really trained to do in med school and residency is marketing, right? Every other business markets themselves. And so what we have to identify is, what do we want to market? The fact that we're there, a new service? Do we want to target certain populations? We hear about March Madness and vasectomy madness, right? So we have it in our mindset that sometimes there's an optimal time for certain patient populations to do certain procedures. So we should really be thinking about marketing and have a budget for that too. Also, when you market, you're marketing your practice to young recruits or lateral transfers. In order to continue to grow, you need people who will come to your culture, help expand your culture, and help your practice grow. One of the things that's really, really difficult in medicine sometimes is we can see the one-on-one. So if I remove a kidney stone, immediately I have that gratification of the surgery's done, the patient's happy, the patient is no longer in pain. But with marketing and other incentives that we do, we don't see the immediate effect of it, and we have to follow it. And if we don't, we forget and we spend money on activities that don't give us the ROI that we're looking for. So metrics are very, very important, as well as accountability. We have to try things. Some will fail, some will succeed, but we need the numbers to prove which one is which.
Some excellent points. Let me ask you about the continued professional development aspect. You're absolutely right. Doctors are so good at it. I mean, even from residency, from us doing presentations, I mean, we've been groomed to be good networkers and do a great job when we go to meetings. But to see, a staff member, a medical assistant, or an APP or a manager, and have them go to a meeting and watch them, start to network with the vendors and stuff like that. It's really, it gives them a sense of pride and really, really energizes them and makes them feel that they're wanted. It does a great deal. And I think that your point is really, really good about that one.
Thank you. Yeah, I think oh, it's you have to recognize that you're the leader of your team. Like, the people you work with really look up to you
Mhm.
and set you sometimes inappropriately at a certain standard. But your responsibility to give back is also paramount. You really need to think about what is next for this person who's working with me, not just for me.
Mhm.
What can I give? What insights in my experience can I give? And they are so grateful for different opportunities that weren't on their radar. And you never know. We personally, we have scribes in our practice, and sometimes even MAs. They go on to med school because of what they saw, what they were exposed to. You never know how you're going to change someone's life.
Yeah, totally agree. That's something that I learned early on was, whenever I'd interview an APP or or specifically a medical assistant, I always said that they were working with me as a team member, not for
Mhm.
me. And I really wanted that distinction made early so they could really feel their worth. So another great point.
Exactly, exactly.
Do you have a marketing person in your practice?
Yes, we do. So, we have a marketing and PR director. And so what she does is she maintains our social media, our website, makes sure our website is updated with any clinical trials we have, as well as new videos that the physicians have done. But also when we have new employees, new physicians, she typically does an outreach to the community and the local magazines and the papers to make sure that their name is out there, saying, hey, they're available for consultations, et cetera, and takes them around. Usually health systems have this physician liaison role, and we try to coordinate with them also. But what we are doing now is also a lot of internal work. We have a new program with patient engagement to hear what the patients actually want from the parking lot to the time that they return to the parking lot, and looking step by step in that journey of what we can do to change to make it a better experience for patients. And then we also turn to the staff and trying to have more activities for the staff to kind of build this more collegial culture.
Mm.
Because we're a large practice, everyone's divided in their pods and not everyone knows everyone. And like many practices, we've had a lot of turnover. So there are new people who are kind of isolated and don't have the same networks. So we're doing a lot of activities internally to try to build that culture, collegial culture. The I'm coming to work because I enjoy what I do. And what I do is to give back to the community.
Yeah, I would say that that's super important, especially post COVID. I mean, it was important. It was important before, but even more now because of all the isolation that occurred. So
Right.
that's really strong work. Let's talk about navigating the complexities of insurance and reimbursement.
Yes. It's interesting because I can tell you honestly, I mean, residency, I went into a health system. So I was an employed physician. Really didn't pay attention to payers at all because on my dashboard that I received, which was going to tell me if I got a bonus, it was only based upon RVUs and it was completely neutral based upon payer. But then once you start looking at the different contracts, so one thing that's important about our practice is we are one of the private practices. So we are a private practice that is also the faculty for Eastern Virginia Medical School. And with that comes resident clinics. There's a large number of uninsured patients. And so we have to balance what we do because we can't give away free care to everyone, but we're also never going to limit the care of anyone who needs the care. So we have to understand how to bill. We have to understand where you do certain procedures. We have to understand when we dictate different procedures, what we need to include so that our coders understand how they need to code. And then we need to audit ourselves. We actually outsource the auditing so there's no bias to make sure. So quarterly, we choose 5 physicians or providers and we have their charts audited. We have a group of people who only code our operative cases so that they're very, very fine tuned into what should be in there, what needs to be in there, and then how it should be coded. There are so many changes happening in healthcare these days. And one of the reasons, I don't think I really understood this before, but the reason why there's so many changes is because the TAM, or like the total accessible market for healthcare, is in the trillions. So which means everyone wants a piece of it, right? So that's why if CMS needs to balance their budget and they're going to pay for X, Y, or Z, they're going to have to take it from somewhere else because there's this huge market that's not going to be able to continue to expand. So we have to pay attention when there are changes in healthcare, either in reimbursement, for example, the public health emergency, like just telemed across state lines. We need to make sure we know, can you bill for that? Yes or no? I know there were recent controversies regarding billing for telephone calls. Well, if you call your attorney, guess what? If you email your attorney, you're going to get billed per minute. But as physicians, how do we feel about billing for phone calls that really should be a visit? Now, I understand if you're calling someone with positive pathology, you feel a little way about calling them and then sending them a bill for that. But what if they're calling for something because they don't want to pay their copay? I think we really need to pay attention to what we can bill for and what we feel comfortable billing for, because at the end of the day, we can't give away free care, but we can be socially responsible about how we deliver the care.
Good point. Question about, it seems like in your practice, there's very specific direction on, when you're dictating your op notes, so your coders get the right procedures coded for. How is that information disseminated to the doctors so that everybody's on the same page?
Well, we have templates. So a lot of times, things are done the exact same way. So for example, we use Epic. So we have standardized templates for consults in the hospital. We have standardized templates for progress notes in the hospitals. I can honestly say in the clinic, people tweak their own charts in their notes. But for certain common operations, let's say Botox, cysto, prostate biopsy, ureteroscopy, we have standard templates so that you can add, subtract, move things around, but the essence of what needs to be in there is in there.
Okay. Are you on Epic both in your clinic and the hospital?
Yes, but we are subsidized by a health system. So on our own, we could not afford to do it.
Okay, got it.
I'll be transparent about that one. Yes.
Yeah, it's always nice when you can be on the same one for sure. How about talking about financial planning and strategy for a urology practice?
Yes. So I remember like initially when I started in practice, the urologist who was getting ready to retire would say, hey, if I'm going to do a TERP, I just write it in this little book and then I give it to the office manager and then it comes back and I just write the amount that I want. And I was thinking, that's interesting, but it doesn't seem like that's going to be in my life, right? So I can't just determine an amount. I mean, I guess this was the 80s. I don't know. I don't want to like date myself, but I think it was not that long ago. Well, we can't really do that anymore. So what we have to do is we have to figure out, okay, how do we do forecasting? How do we know how many people we need to work to service the community? How many physicians do we need? How many patients do they need to see a day? How many APPs do we need? What services do they need to provide? And with all of that information, you can create templates for daily number of patients that need to be seen. You can create forecasting models of if you see, I don't know, I'll make up a number that's crazy, like 80 patients a day, this is how much you should generate. But you also have to put in there a model where people have time off, right? None of us can just run this race forever. We need to have a break. We need to have mental downtime where we have no responsibilities. And so you also have to model for that. So every single year, we put together a budget. And then as we go through quarterly, we're looking, where are we compared to budget? I can honestly tell you, sometimes we are off. The pandemic, I could have never forecasted, right? So there's times that you're definitely off. But if you set goals about what you want to do, what you want to complete, it's amazing. If you have no goal, you're just kind of on the lazy river winding through life. But if you have a goal, you're going to do actions that bring you closer to that goal. You have to benchmark yourself. There are different software, and we use Athena for our revenue cycle management. So you can see what like practices are doing. Okay. How many hours a week and a month are physicians available? I mean, if you only work 2 days a week, it's going to be a very different model than if everyone's working 4 or 5 days a week. You want to have KPIs or key performance indicators. Now, I can honestly say as physicians, we don't like being told what to do or what we need to do. I mean, we're very independent souls, right? But we need to have benchmarks. And instead of just setting an arbitrary number, we try to internally compare ourselves. So we put out dashboard that has everyone's number. It's not blinded. So again, it's kind of that, hey, everyone's working hard, but it looks like maybe you need some help either seeing more patients, maybe you need a scribe, maybe you need help in the OR so you can do more than 2 cases a day, just little things that may help. But the KPIs for us are very, very important because then we can at least benchmark each other because we're in the same practice, same community, even though we're different subspecialties. And the other thing is everything's managing risk, right? If we can see what's coming down the pike, and a classic example is PCR, right? So we could see in the past a lot of groups got PCR, and then certain, let's say Palmetto decided not to cover it, and then it's just be careful of what you decide to do and make sure you're doing it for a correct clinical reason, because then you'll never feel like you were at fault. If you just do things or set up models just to bring that revenue in, you could get caught out there if it's not clinically appropriate for patients.
So, in today's world with, doctors retiring earlier, the number of patients going exponentially, how going back to your point about budgeting, forecasting, and setting financial goals, how do you align the required or not required, but how do you align the goals of your financial goals with those of individual physicians? And I'll just throw out an example. Say a guy that's in his late 50s, like me, that wants to start slowing down, and they don't want to work 5 days a week. They want to work 4. And obviously they're still very helpful and important in the practice, but they're not gonna, their desire is not to run that crazy mouse wheel all the time. How does your group align to individual physicians?
So what we've done is we provided options. We provided kind of a slow path to retirement. So prior to COVID, we were 5-day-a-week work week. Everyone just grinded it out for 5 days. During COVID, we recognized that one, patients weren't coming as much, so there's no reason to have people just sitting around looking at each other. And so we provided additional 2 days off a month. Now, we are one of the groups that has an exceptional vacation plan. So those 2 days ended up being a total of maybe 70 days off a year. So a lot of time off just for mental health and exploring. I mean, we're in Virginia Beach, so it's a pretty nice area to spend most of the year outside. But then as the public health emergency stopped, we realized, okay, we do have a backlog of patients. Our job is to provide access. So we hired APPs, as well as we went back to work an additional day. So for the physicians who are like, hey, I've been doing this for 30 years. I'm getting tired. I still love what I do and I want to contribute. We have a model where you can either work 90% or 80%, and you can choose. And your salary and benefits are commensurate with your FTE status. So let's say you're at 80% and you're like, all right, I'm working 3.5 days a week. Everything's fine, but now I think I want to retire. Well, in our group, in the model that we have, you're no longer a partner if you fall below 80%. So you'll get bought out from the partnership, but we do have this post-retirement part-time physician track. That's an employed physician. And I can tell you honestly, when people want to give up practice, what do they want to give up? Clinic or OR? It's always clinic, right? So we have a model where, I mean, we have more than enough procedures that we just can't get always done in a timeline we would love to. So we have our part-time retired physicians come in and maybe work 1 or 2 days a week. They do biopsies, they do cystos, they do ESWALs, they do vasectomies. And for them, they are still contributing to society. They are really helping the group. And there's not that much follow-up. We follow up those patients. So they get to enjoy the best part of being a urologist. And so it's kind of a phase out plan where it's not an abrupt one day you're working 100 hours a week and the next day you're at home. So it helps everyone. And the guidance that they provide to the younger physicians is amazing. I mean, they have so much knowledge that hasn't been tapped just because everyone's so busy. As soon as you start slowing down, you're able to have those conversations. You're able to make those recommendations. Hey, I saw this before. This is what I tried. This worked, but this didn't work. So maybe you try it this way.
Yeah, honestly, that is literally one of the best plans I've heard of. And I congratulate you guys for identifying that, the physicians that are slowing down are so critical and deliver access to care that, otherwise if they just quit, I mean, it's a lose for everybody. So great job there.
Thank you.
Let's talk about the future. Emerging trends and financial implications.
Yes. So as we saw with, I will always say COVID changed everything, right? It just really made us all step back and evaluate just what our healthcare system really is and what it's based upon and what the support structures are and aren't. Just how we manage our own mental health and our balance, what we value, which is our health, our family. And so as things have continued to kind of migrate into this new model, we really have to appreciate the impact of telemedicine and the fact that it used to be that if you didn't lay hands on the person, then you weren't really examining, et cetera. But when everyone was at home during COVID and we did telemedicine, we still delivered care. There's so many things that you can describe, understand, and you can still treat patients without physically touching them. And if you look outside of urology, I mean, it's massive. There are these national centers that patients can go either through their insurance or just log in and get a physician for their UTI, et cetera. Now, we as urologists don't recommend that, but still, that's what patients want. They want like on-demand care. So we need to figure out a better way to deliver it because that's what our customer or our patient is demanding. The digital model. So people want to be able to get care on their phones. They want to be able to communicate back and forth with chats. And it used to be that we would say, okay, well, the 90-year-old patient, they want to come in and write everything down. No, our 90-year-old patient's like, hey, my granddaughter's on FaceTime right now. Can you explain it to her again? Like people are using this digital technology and we need to appreciate that. And there's implications, right? Because so many things are accessible on their phones. If you're not available, if you're not able to provide the care, they can quickly find someone else who could. And it may or may not be the right decision for them. So you really need to make sure that the product, the care you're delivering is appropriate and also financially feasible. Right now, there are so many demands on our patients, from drug pricing to gas to just everything is much more expensive. And I can say some wages have gone up, but not appropriately for inflation. I mean, our whole society cannot compensate for what's happened in the past 3 years, which is the inflation that's just rampant. But one of the things that we have to pay attention to is we've all grown up in this fee-for-service model. It's going to change. It's first changing with medicine. They're figuring out how to maneuver, how to deliver value-based care. And I've always seen that if you don't take the reins and lead and guide, someone's going to make decisions for you. And they're usually not appropriate because they're not the ones actually delivering the care. So our next generation really needs to think about, okay, what is value? What can we demonstrate? What can we show with data that's providing value? Because when these payers decide or figure out how to switch these contracts, we cannot be left flat-footed. I think another thing that we really need to consider is technology is going to change. We can see already, and everyone who was at the AUA could see in the product theater, all the new technologies that are out there, things that you can assess from home. Like, they don't have to even come in. You can log in and you can see what their Euroflows are. Like, it is amazing how many things have changed in the last like 3 to 5 years, but we need to be prepared for that. We need to have systems in place. We need to understand what it means and understand, one, how to use it, how to deliver care for the patient, to explain to them how to use it, and also how to bill so we can recapture that revenue.
Good points. Let me ask you a couple questions about telemedicine. So, I didn't get to the AUA advocacy meeting this year. The last couple of years, we've kind of stomped on the hill about, having the telemedicine continue after the public health emergency ended. But it was going to take congressional action for that to happen. And the Telehealth caucus was involved, and everybody that, all of the representatives and senators in Arizona were very on board with it. What's the status of telemedicine and telehealth right now, as far as the public health emergency, and then insurance is reimbursing and that kind of thing?
So right now, our payers are paying on par. So they're paying the same. So we have the option for the commercial payers to do telemedicine as long as in the same state. Where we are located is in an area where we also have an catchment area of Northeast North Carolina. And unless you have a license to practice there, it's not really an option. It was during the public health emergency. Now we practice within the state. Now, some of the other payers, let's say governmental payers, are not as flexible or reimbursing on par. So when a patient requests telemedicine, we have our billing team look through and see whether or not their individual payer contract will reimburse for it. And we advise the patient at the time. Now, they still pay a copay if everything is covered, et cetera, but we utilize it when needed. I would say that for many times it is efficient. Those visits are more direct. If we look at just the patient journey of how long they spend in the office, coming in, completing paperwork digitally, hopefully, giving your urine, waiting for the doctor, waiting in the room, that's a long ordeal, definitely more than an hour. But when you do a telemedicine visit, it's much more directed. They're much more focused on the actual problem. Your conversation doesn't deviate to grandkids and cats, right? Maybe it's just my patients and the women I see. It's much more focused on the problem because now you're immersed in their life, in their home, and they probably have something else to do as soon as they finish. So it's about recapturing time. So I'm very hopeful that telemedicine has been recognized as a very positive change in healthcare, that it's providing value. I do hope that it continues to be paid on par. Otherwise, the utilization will be less.
Yeah, I think you've made a couple great points. And I would agree with you that I was surprised as well, but some of the older patients are actually the happiest with telehealth because, it's harder for them to get in the car and drive and everything. So it made a huge difference in the older population in Arizona. The other thing that was kind of unique here in Arizona was, north of Phoenix, healthcare access is not readily available. And we would have people drive from northern Arizona 2 or even 3 hours one way to get their biopsy results, and so having the ability to do telehealth for that was just a game changer. So it's really changed for the better for the patients, for sure.
I agree. And then I really think rural health, at times my heart bleeds, just the lack of access. And honestly, driving 3 hours, that is a lot because the costs involved with that. That's an entire day trip.
Yeah. Exactly.
for one result. But I think we also need to recognize that there are Wi-Fi deserts, right? So there are areas that are not going to have this fast streaming broadband that people who are in a more suburban or urban area appreciate. So we want to recognize both sides.
Great point. Well, thank you, Dr. Miles Thomas, for sharing your time and expertise with us today.
Well, thank you. I really enjoyed this conversation.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Thank you.
Thank you for listening. If you enjoyed this episode, make AUA Leadership in Business your go-to podcast. Subscribe today by searching AUA Leadership in Business on your favorite podcast app and enhance your leadership and business education needs.